all, I just have to say thank you for allowing me to switch. We got a big snowstorm hitting Minnesota tomorrow, so I want to get home before it happens. I'm going to talk with you today about Health Partners Children's Health Initiative. I'll spend most of the time talking about the work that I've done on adolescent sexual health. But first, just a little bit about Health Partners in general. Park Nicollet merged with Health Partners in January of 2013. I didn't really know very much about Health Partners at that point, other than my sister worked for the plan. So Health Partners is not only a health plan, but also has multiple hospitals. They've been acquiring medical groups. They have dental clinics and also a very robust research and education department. We have over 750 primary care clinicians at 50 different sites, primarily in eastern central Minnesota and western Wisconsin. So Children's Health Initiative is really the brainchild of Mary Brainerd, who was the former CEO of Health Partners. And in 2014, she put together a group of people to look at how it could improve the health of children, not only in our care group, but also in the community and in the state, leveraging the resources that we had through the plan and through our care system. And this group spent a lot of time thinking about where they wanted to focus their energy. I wasn't part of the initial steering committee, but joined later in that year when I became chair. The three areas that they decided to focus on were promoting early brain development, providing family-centered care, and strengthening communities. And each of the focus areas underneath these umbrellas have very active projects going on with them. I'll just briefly tell you what's happening with each of the groups, and then we'll focus most of the time on preventing teen pregnancy. So Retoxing, we brought in the National Reach Out and Read organization, which works with clinicians and staff to discuss the importance of early literacy. How do you talk to patients about it? We hand out books from age 6 months to age 5 at well-child visits. For social emotional development, we standardized social emotional screening and autism screening throughout primary care at all of the clinics. Healthy Beginnings is a program that screens all pregnant women at the first prenatal visit for drug use and doing universal urine tox screens. And we have care coordinators that work with that group, and they reach out to any positive screens and any high-risk women. Breastfeeding promotion, we've embedded lactation coaches and champions in each of our sites, done a lot of breastfeeding education. Some of the hospitals have been designated as baby-friendly hospitals, and we've also increased our own lactation rooms and made them nicer for our own employees. Postpartum depression screening, we have standardized using the Edinburgh screen throughout the whole care system in primary care and in the OBGYN. So we're doing it at prenatal visits as well as postpartum visits and well-child checks up through 6 months. We're currently working on a standard way of approaching positive screens. Pediatric standard workflow, I was part of that group, 3-year project to basically standardize all of pediatric well care throughout the whole system from birth through age 21. We created visit notes that everybody's required to use. There's standardized screening, risk assessments. We made smart sets. We changed our Epic navigator. So lots of work around that. And that went live June of last year. The OB standard workflow group is following in the footsteps of pediatric standard workflow and again trying to standardize all OB visits throughout the system. And Family Community Connections is doing home visits to high-risk moms and babies. The Reducing Disparities group is still really trying to find their way. They're partnering with some groups in the community, trying to figure out where they're going to focus their energy. And then we're going to really focus now on the Preventing Teen Pregnancy group, which ultimately became the Adolescent Sexual Health group. You might be wondering why there ended up being a Preventing Teen Pregnancy group kind of in the midst of all of these other focus areas that really look at basically early childhood issues. And the backstory on that is the same time this focus group was meeting in 2014 to figure out where they wanted to, basically focus all their energy, there was a study published in JAMA by Health Partners Institute that looked at missed opportunities for preventing pregnancy among health partners insured adolescents that were seen. So these adolescents all had health partners insurance and they were seen at health partners medical group. And what they found was that on average, in the year prior to becoming pregnant, there were at least 3 visits to primary care before that pregnancy occurred. 50% of the time, there was no documentation of sexual activity. And 47% of the time, there was no documentation of any kind of reproductive health counseling. Only 35% of them were prescribed a contraceptive, and only one of those was a long-acting contraceptive. So we all know that there are lots of consequences of teenage pregnancy other than just a baby. Up to 50% of teen moms are not going to have a high school diploma by the age of 22, compared to 90% of teenagers who aren't mothers. Teen moms are more likely to be unemployed and live in poverty. We also know that infants and children are really affected by the stresses that are affecting their families, and this can affect their learning and long-term physical and mental health outcomes. So one example of one of the disparities that can happen as a result of learning problems is if you look at the number of words in a child's vocabulary, we can see as early as 18 months that there becomes a disparity between number of words spoken to children born to college-age parents or college-educated parents versus working-class parents versus parents on welfare. And down the road, this has numerous consequences, not the least being that the best predictor for which children from all age groups will end up in prison by age 18 is the number of words in each child's vocabulary at kindergarten. So George Halverson was the CEO of Health Partners before Mary Brainerd was. So I think Mary Brainerd is, he was very much of a mentor to her, and he's done a lot of work on this in California. So we actually had George come before we really got going on everything and talking a lot about the work that he's looked at as far as disparities. So the group really felt that in order to have an effect on all of the other issues they were working on, they really needed to start upstream and figure out how to prevent some of these pregnancies in the first place. So we started to look at how we were going to do this, and it became apparent very quickly that we had a much bigger problem than just how to prevent teen pregnancies. And so we really had to broaden our focus to looking more general at adolescent sexual health. The biggest barrier, honestly, to dealing with this were clinicians themselves. And part of it was that people just were extremely uncomfortable talking to adolescents about sexual health. And I have to say, a lot of the pushback came from the pediatricians, not so much from the family medicine people, and I'm not sure if that's because they thought I would get mad at them if they pushed back on this or not, but we realized that we needed to tackle that problem. So it wasn't just discomfort, it was also the fact that they really didn't have any tools that helped to facilitate those conversations. Our clinics weren't really set up to have the expectation that that was going to happen, and there really wasn't any protected time for them to have that conversation with the youth, with the parent not in the room. So we tackled this in a multifactorial manner, and I'm going to go through just briefly some of the things that we did. One of the things we did was create a counseling tool so that people could actually talk about different methods of contraception. So I was actually shocked that we didn't have anything. People were using random stuff that they copied off from medical school and were still using. Some people were using best practice evidence-based approaches, but we pulled together a lot of the best practice materials, gave it to our patient ed department. They came up with this. which is really the way we should be counseling all women about contraception, starting from the most effective down to the not as effective, and emphasizing LARC as first-line choice even for adolescents and young adults. Next, we tackled the concerns people had about what they could actually legally talk to a child about. As you probably know, the laws vary dramatically from state to state. I trained in California, practiced there for 8 years after residency, and I was shocked when I moved to Minnesota and found out what I could or couldn't say to anyone there, because it was totally different than California. So we had our attorneys meet for over a year to come up with a guide to minor consent for both Minnesota and Wisconsin, which are completely polar opposite states too. So that made it even more complicated. And this is embedded now in our EPIC and at our front desk, and people have access to it and know it exists. So the next thing we did was figure out a way that we could tell our patients that we actually wanted to change their well visits. And so we came up with some letters. The first set of letters was for the parents of the 10 and 11-year-olds. And they basically outlined what we wanted them to, what we hoped to do at their well child visit. And these were, the different things that they could expect that would be discussed. And then they also set the expectation that once they were 12, that the parent was going to be asked to leave the room and there was going to be one-on-one time with the child. Oops, I did something wrong. There, okay. And then another set of letters for the 12 to 18-year-old visits. One letter goes to parents, one letter goes to the youth. Parent letter says what's happening and that your child is going to be getting a screen. We want you to let them complete it in private, and then they'll be discussing it privately with the clinician. And then for the kids, the letter talks about, here's all the things you can expect, and we hope that you feel comfortable with your clinician and can have these conversations. And then we came up with a questionnaire. And the goal of the questionnaire is not just to basically get everything out on paper, but it's also to prioritize what the issues are so that the clinician can focus in on what may be important to that child on that day. So here's some examples of some of the questions. I circled the area that really our whole project almost got derailed by because it actually has questions about sex. Have they had sex? Have they ever traded sex for money? Have they wondered if they're lesbian, gay, bisexual? So people were really uncomfortable having those questions asked because they didn't know what to do with the answers if they got them, and they didn't have a lot of resources to refer people to. So we had to do a lot of work on figuring out resources for them, but we also realized that we had an even bigger problem than we knew about, and the fact that people just didn't even think it was important that we ask these questions. So we created a video to train people about why it was important to talk to youth about sexual health, how to do it, and so it's a 30-minute video. We partnered with one of our local teen clinics, and it was in an interview-style video with these two clinicians from the clinic and a health educator. We had snippets from kids talking about what they were hoping to see in their well visit, bad experiences, good experiences, snippets from parents about what they expected clinicians to be talking to their child about. And it was very well received and allowed us to actually roll this out. So, anytime you do a big project like this, and especially when you get pushback from people, sometimes you think, well, is this even worth it? Why did I even start doing this? So we rolled this out June of last year, everything, all the pediatric standard work, plus all the adolescent stuff. And about a month later, one of the family physicians in my department sent me an email that I'm going to read to you. that really validated why we did this. So, she says, "Hi Shannon, I don't want to take too much of your time, but I wanted to let you know about a jury duty case that I was on last week. It was a criminal case between the state of Minnesota representing a 13-year-old girl with sexual assault charges against her father. The bottom line was that the 2 weeks of jury duty was very interesting, but a very difficult experience. Why I'm telling you this was that the only reason she told anyone about her father raping her was on her 13-year-old well child check. On the teen screen, there's a box which asks about any history of sexual or other physical, verbal, etc. assault. In the court case, they brought up the teen screen in great detail, had the resident who had seen the patient on the stand along with the pediatrician. The patient/teenager, when asked why she did not tell anyone before this, said, quote, because no one asked. She'd been to the same pediatrician for about 10 years. It had been going on since the age of 6. It was a very complex case. The mom knew, but told the daughter to keep it a secret as she was ashamed and that, quote, no one would believe her as she was just a kid. It was eye-opening, but really the teen screen saved this girl's life potentially and put her father in jail for hopefully a very long time. I thought you would find that interesting, and I know I will be looking at the teen screens much more carefully from now on. So, that was for me good validation that all the hard work was worth it. So, we're still not done. Moving forward to try to get more people trained on doing LARC in our clinics. We're also hoping to do same-day LARC appointments. And we're trying to get a research grant to do some research on piloting the electronic capture of the teen questionnaire. Currently we use a paper version, then we tell kids that it's going to be shredded when after they review it with their clinician. But we're going to ask the question of them of how comfortable they would be storing it or not, because we've actually never asked that. We just assume that we shouldn't put it in the record, but so we'll see. Long-acting reversible contraceptives, so IUDs and Nexplanon. Yeah. All right, so that's it. So, I really wanted to talk about this because I feel like this is an area that a lot of groups struggle with, and it's important to see what's out there as far as what people are doing, and hopefully you can get some ideas to bring back to your own departments and clinics. Yeah.
Just a very quick reaction. Do you think Google and what is that, Alexa, you think they'll be in the home listening for this and talking to mom, dad, and the kids?
Interesting thought.
I just thought I'd throw that out there. Where you might be.
I think it's great what you're doing. We all know what really needs to happen is not that many of them come into our office. What really needs to happen is it's got to happen in the schools, all the same stuff that you're doing. The sad thing is they do that in most of the European countries, and they have like a third the rate of our unintended pregnancy, but we haven't got our morality issue there yet where we think it's okay to talk about that stuff. But it's great what you're doing.
So one of the projects that I was working on sort of at the same time as we were developing all the adolescent sexual health things is a COIN project with the Minnesota Department of Health, and I can't remember what COIN stands for, but we were funded along with 4 other states to look at how to bring value to the adolescent well visit. And so as part of this, I didn't mention that because it really wasn't part of the CHI thing, but we had youth and young adults come into our clinic to rank us to see how youth-friendly we were. They gave us suggestions as to how we could change things to make the clinic more youth-friendly. And so that was really crucial. We also asked, we had focus groups of adolescents as part of this project that I just talked about to see what they wanted at their visits. And so they actually were the big push behind some of the questions that we asked on the teen questionnaire, which is why we were so adamant that we had to do it. Because I had clinicians saying, you got to get rid of those questions or we won't do this. And I said, absolutely not. This is what the kids want. They want to be asked these questions, and we're not doing it unless we do this. So you guys just have to get comfortable with it.
I had the opportunity to work in a school-based health center for high school students, and this was standard. If they came in for a cold, headache, every student was screened every time, and there was a social worker on site, so it was just the accepted norm, so. But the truth is, I never really, insisted that we do that in our routine clinics, and that's the disconnect.
Yeah, and we have 5 school-based clinics that are funded by the Park Nichols Foundation. And, right, we screen in those, but we weren't doing it on our other sites. The irony, though, is that we haven't figured out funding for LARC in the school-based clinics, so they're handing out birth control pills. They're doing depot, but we're really pushing that they at least get Nexplanon in there. If we can't get everybody comfortable doing IUDs, at least they can put a Nexplanon in.
What do you do when the parent says, no, I'm not leaving the room?
So that's just a conversation. That was actually one of the pushback from people, right? Well, what do I do if they don't want to go? Well, they don't have to. I mean, we're not forcing them to leave, but that would just be, I think, a really great opportunity to discuss why we're doing it. The letter outlines it very nicely why we're doing it, and we have not had anyone not do it that I've heard of. And believe me, I think I would have heard about it because people were so stressed about that. Yeah.
Yeah, in our practice, we do the same thing. We go through and we ask the parents to leave, and we have, your questionnaire is way better than ours, but, and it's, to me, it's so rare that it happens, it's a red flag that something else is going on
Right.
in the house.
I was just curious, what parts of these tools are shareable? Like, are the letters or the
All of them, except the
exams?
video, just because of the type of consent that we got, because there's minors in the video and how it was consented and everything. But yeah, I could send you copies of all of the tools.
Email you.
Okay.
So, in my career, I've never had a parent say no when you ask them to leave a room, so, I mean, it's very unusual. My question is, we have a wide range of religious and cultural beliefs in our communities, and some parents are very open, and some parents are not very open. And so, two-part question, do you have to address culture, religion, and those kinds of things? The second thing is, well, in Minnesota, you can address and provide contraception without the parent's consent. In Michigan, we had, for a while, a problem with the explanation of benefits, outing the teenager for the care they had received. And have you seen that, and did you work at addressing that?
So we still have the EOB problem in Minnesota. Not so much about contraception, but it would be more like STD testing, right? Because that's what they could pull. So we always tell them, and that's actually part of the letter, that this visit is confidential. However, we can't guarantee 100% confidentiality. If the parents really wanted to, dig, they could, and if you need that, then we have other clinics that we refer people to. And then as far as the cultural issue goes, we actually, as part of the video, we had one of our Somali providers talking about some of those issues. And I think, it's just being culturally sensitive. And again, if parents aren't comfortable leaving, it's certainly not forced. Everybody gets the same letter, but it's always a conversation.
I kind of hate to ask this question because it reflects my own ignorance. But when I think about Wisconsin, when I think about Minnesota, they seem like they're very similar.
I know.
So I'm curious as to what the big disparity
Well, they
was.
vote differently in general, right? So maybe that, we won't go there. I don't know why it is, it's different. I think their legislature is just more conservative in Wisconsin. But I don't live in Wisconsin, so I can't really say, but I do know that it's just a lot more restricted as to what they can talk to people about.
One's blue and one's red.
I know, well, yeah.
What you had up there, I'm from Wisconsin, I'm from Wisconsin, and what you had up there is the same rules we have. So I mean,
Well,
that's-
that was the Minnesota one, and yeah, so some of the rules are the same, but some of them are different. I didn't have the whole thing. We had, it's like a 2-page thing
Okay.
that we have, yeah. So some of the, especially the mental health and substance abuse rules are different.
So what I really love about you is you approach this in a systematic way to address the content, the people, the implementation, the training, getting it into the workflows, and I'm hoping measuring your outcomes.
Yes, we're working on
And
measuring now, yeah.
that's something that's a great case study for how to implement something well. And lots of times we get asked to lead stuff and failure to attend to your stakeholders or some other aspect of that kind of kills it. I worked in a setting in a community where there was a number of parents, and I want you to comment a little bit about parents and the backdrop, particularly around adolescent sexuality. Because I had a group of parents who are highly involved, many of them were homeschooling, and from a values perspective, they wanted to be open and have conversations, and they weren't particularly wild about hormonal contraception. So the aspect of that we ended up needing to address was working more intimately with the parent-child unit, which in some settings, in the urban setting now, is really difficult. But in that setting, worked well, and their argument was, I want to teach my children, my daughter, my sons, about how to approach their sexual health from the perspective they can use sort of an internal governor and or internal mechanisms and scripting, which became part of it. So where we ended up having to make the investment was actually very heavily more with the parents and socializing. So I was wondering if you could talk a little bit about whether you have a patient advisory group and whether and how parents might be available to talk about the issues around adolescent health, even beyond sexual health. With other risky behaviors, we could just name it that way.
Yeah, so the Annex Sexual Health, or Annex Teen Clinic, I guess is what it's called, that we partnered with to do the video, one of their big community projects that they do is parent education groups. And so they'll have a couple hour education sessions with parents to teach them about sex ed, basically, and how to talk to their kids about it. And because they really value that connection, and even the people that were on the video from the annex talked about how, parents, when they're asked to leave the room, there's always this conversation that we have that, this is not, we don't want to keep secrets from parents. And that often what will happen is you'll have a conversation with the youth, and the part of that conversation will be, maybe we should talk to your parents about this, right? And actually one of the vignettes that we had was one of our family doctors who had seen a child for several visits for ADHD, and then had a visit with the teen screen, and had the parent leave. And this was, I think, a 13-year-old. And on the teen screen, the child didn't check the box. Have you been concerned about being, or have you ever thought about if you're lesbian, gay, bisexual? And they didn't check that box. So she actually asked the child, you didn't check this box. And the kid looked at her and said, there's something I've known about myself for the last 2 years, and I haven't told anybody. And at that moment, she told the provider that she was really a male. And so they had a conversation, and the provider said, your mom's really supportive of you. She's here with you all the time. What do you think? Should we bring her in? Do you feel comfortable telling her? And so they did, and he told her. And for this provider, it was probably the most rewarding experience she'd ever had in her career. So really, the focus isn't we get the parent out of the room so we can just have this private time. It's how do we connect the family together with the whole thing? And that really wasn't happening at all before. I mean, who knows how long this relationship with parent and child would have gone on before child told the parent, they were really a boy. So, no, it's been good.
Okay, thanks a lot, Shannon, appreciate it.